Good afternoon, everyone. So, today I'll be talking about early post-operative challenges in microvascular free flap surgery. So, coming to the introduction, we all know that free flap reconstruction following head and neck tumor ablation is a routine practice, and because of the advancements in the microvascular surgery, it is very rampantly done these days. The post-operative complications can be daunting, and documentation of these complications is needed so that we help our patients and we improve their outcomes. So, microvascular free flap tissue transfer is a reliable method for reconstruction of complex surgical defects with a success rate ranging from 91 to 99%. It's a broad spectrum. A high rate of success is likely attributable to the technological advances in magnification, that is the use of microscope, the finer and better suture materials, the surgical instruments. Yesterday, Karthik had told that instruments play a vital role. Yes, in microvascular reconstruction, also specialized instruments are needed, which should be available, and also a magnification microscope. And increased surgical experience with microsurgery is also needed. There is no alternative to a good adequate training. Whenever you have decided to go into microvascular surgery, you have to be trained very proficiently. And despite of all these factors, yes, we do face issues, and in view of multiple factors. So in this talk, basically I'll be highlighting what immediately can go wrong. So what happens when there is a complication? It psychologically it is devastating. Yesterday only Sultan Pradhan sir, he said that we have to bring the patient to a level where they are able to live with a dignity. So that can only be done with reconstruction. And if it is a failure, then it gives them a poor quality of life. So everything starts in the preoperative period only. When you see the patient for the first time, you have to take a thorough history. Then whether it is a primary reconstruction or a secondary reconstruction, that has to be decided. Flap selection is very important. It depends on the body habitus of the patient also. I would like to highlight on the preoperative counseling. Whenever the head and neck surgeon has seen and they have decided that it will need a free flap, you are meeting the patient for the first time. You have to counsel them properly. You have to give time. In counseling, of course, you have to show them hope, but also you have to tell them about the likely complications which can happen, so that if at all in the post-operative period there is anything wrong, they already know about it, and they also know that we will do our best, whatever is there in our armamentarium. Another factor is patient factor, which are the risk factors. So regarding flap selection, this is what I meant. Morning, Dr. Prashant Puranik, he told that a flap should not be very large in a small defect, and the vice versa. So this picture, it basically explains it all. If you have not selected a proper flap, you are stuck. So the patient factors, risk factors are the comorbidities, old age, atherosclerosis, yes, NACT because it is prothrombotic, and salvage cases, which is secondary reconstruction. So no complications, we might just leave it. No, let us openly talk about it. So what can happen in immediately post-operative period? Acute neck bleed, hematoma, and external compression of the pedicle. These are all non-microvascular related complications. And microvascular related complications can be venous insufficiency and arterial insufficiency. So this is a video. This is, I think, day 0 itself. This happened. The patient was in ICU. So as a protocol, we keep the patient in ICU for 2 days. And this happened on day 0. You can see the bleed is coming out from the neck. Looks like a fresh arterial bleed. This is one of the indications to take the patient back to the OT. You really should not wait. Again, high colored drains, continuous flow in the tubing, and also there was some swelling in the neck. This is again an indication to take the patient back to the OT. Now, this was, I think, day 2. The bleeding was between the surface. This was a marginal mandibulectomy along with radial forearm. So there was a hematoma and there was continuous ooze from the area where you can see the flap has been inset to the area of the commissure. So this again we took the patient back to the OT. Now yesterday a lot of discussion happened about drains. So I have this very rare picture wherein the drain was not fixed properly and it curved like this and it nicely went and it sat on this microvascular anastomosis here and it killed the flap. So the management of the drain is like very important. Now again, not every hematoma and ecchymosis is very alarming. You can wait also. This is a case where you can wait. There is only ecchymosis here. This was a case of infrastructure maxillectomy. Day 4-5, she started having this bruising along the tunnel area from where the pedicle was being delivered into the neck. So there is no swelling, there is no ooze, the flap was good. It's only localized ecchymosis. In such cases, you can wait. Now, microvascular related complications. Multiple pricks, obviously it is seen that we were anticipating something. All these hesitation marks. Yeah, this is a classical picture how a venous congestion looks. It is brisk, it is dark colored. I hope everyone has seen how a congested flap looks. So this is it. Wherever you prick, it is dark, it is coming out swiftly. And this is a case of arterial insufficiency. You can see multiple bold pricks have been made on the skin paddle, but there is no bleed whatsoever. You can see that the entire area is white. So here we are suspecting that there is arterial problem. It's visible, right? Yeah. So, Karthik, it's not 12:30 in the morning, but it's Sunday morning, and you get a call from Ashima saying that I've sent you a picture. Okay, this was the picture, a disaster. So, for avoiding all this, you have to have prevention. So, always prevention is better than cure. So, how it is? You anticipate. You've seen the patient in the preoperative period, all the risk factors, primary reconstruction, secondary reconstruction, everything is decided. Then you have to anticipate that, okay, if this is there, I may face this, this is there, I may face that. So, planning and discussion with a fellow head and neck surgeon. I'm very lucky to have Karthik and Sriram. So, we very well discuss whatever we are going to do, and even if you have decided that you are going to do, suppose you decided in the pre-op that you are going to do a radial forearm, you should not go with that mind. You have to go with an open mind, that you will be able to change the plan of reconstruction whenever you want to, and however the defect is demanding. It depends on that. So this is what I meant. Donor site selection can change intraoperatively also. Then again you have to see the course of the pedicle. Always mark the lie of the pedicle so that it doesn't get kinked or twisted or whatever. Then you have to assess the quality of the vessels. Then again drains. Everyone agreed that yes, drains have to be inserted before the microvascular reconstruction. Putting a drain stitch properly to secure it. And intraoperative map. I will not say much about it. I can see the notes are here. So after that you are done with the surgery, you take the patient to the ICU monitoring. Now, thankfully we are not in this era where, pigeons will deliver us the news that the flap has gone blue. There are multiple other things which are available. So we in our institute, basically we rely on prick test, and we also do Dopplers. So according to me and whatever experience I have, there is no alternative to prick test. I mean, I totally rely on it. And we keep the patient in the ICU for 2 days, like I told you. And after that, we shift them to the ward. In the ward, we do Doppler monitoring. So it has many times happened that, because we want to sleep peacefully, we do Dopplers, and sometimes we forget to mark the area of the Doppler and we run back just to put that marking. So in breast reconstructions and other form of reconstructions, 48 hours monitoring is fairly enough. But in head and neck reconstructions, it has to be done at least for 5 days. Why? Because it is dependent on many factors. One of them is the neck movements of the patient. Especially if you're doing end-to-side anastomosis, in those cases, they can be kinked, or if the patient slept on that side, or if the vein is superficial like EJV, it can get compressed and some catastrophe might happen. So that is why at least for 5 days you have to monitor the flap. And there should be no bulky dressings over the neck. Same reason, so that the pedicle doesn't get compressed. Okay, now the videos which I've shown you, something of that sort has happened and you plan to salvage the flap. So, first of all, what to do? Non-microvascular complication, I panic. After that, I accept it and I ask for help. In early detection, low threshold, thankfully our ICU staff is very good. They detect, they call us, and we have a low threshold to take the patient back to the OT. And our OT staff and anesthesia is always helping us around. And once everything is decided that, okay, we are going to take this patient, you can temporarily, when the logistics are being arranged, you can open a few sutures in the neck and just see what is happening. And the entire system also gets little bit of decompression. Obviously, hemodynamic stability is important, so that you have to see for BP, pulse, everything should be stable. Anesthesia should be informed. And also, you should keep the potential source of bleeder in your mind. So there are many bleeders. This is a long list which was given to me by Karthik, and you can read it. I would not say that all re-exploration bleeds are related to neck dissection. I've written here the undersurface of the flap also, so otherwise all head neck surgeons will feel bad that they are blaming it on us. And also you should also be ready for negative re-explorations, where you might not find anything, you just give a wash and you come out. So when you are in the OT, you start with a baseline prick of the flap, in the ICU, sorry. After that, you arrange the logistics. By that I mean microscope, instruments, everything. When in the OT, open the neck, the pedicle is to be seen first. Confirm that there is no bleeder from the pedicle itself, from the anastomotic side. If it is secure, then you start searching for other bleeders. When you find them, clip ligate. Confirm again with the Valsalva maneuver. Wait for 10 minutes. Check again for the bleeder, for the flap bleed also. Give thorough washes and come out. So, this is what we basically follow for non-microvascular related complications. Now, coming to the microvascular related complications. Has any one of you draped a microscope before? I think that is one of the toughest part to start with for any microvascular surgeon. But yeah, there are other things also. So, venous thrombosis is more common than the arterial thrombosis. Why? Because it is a low flow system, it is prone to stasis. It gets easily kinked with a tight closure, and also the neck motion, we have discussed this. But the silver lining in this dark, congested, brisk bleed is that the salvage rates are higher compared to the arterial. Why? Because it is detected earlier. Whenever there is venous congestion in the system, the entire flap, if you've taken especially muscle along with it, it starts to ooze and there will be hematoma formation. That catches your eye. Then you go and prick the flap, then yes, it is congested. So that is how it is. Arterial thrombosis is basically depending on the handling, and it is technique dependent also. So the course of the artery and how you're placing the vein and the artery during anastomosis also has a role to play here. And if the artery is very calcified, or there is atherosclerosis, you can see here how it is getting kinked. So every time this was getting kinked, the bleed in the flap was going away. So you have to see the kink or the lie of the pedicle. So here what we follow whenever we have microvascular related complication is that we start by local re-exploration. That is very subjective, but I prefer opening a few sutures and just have a look at the pedicle. You will come to know if the vein is collapsed, that means the entire system is not working. Then you take to the OT, open the artery and vein depending on what you are anticipating. Then you have to flush a paralyzed saline, take out the thrombus, either using the micro instruments or by milking. Once it is clear, you redo the anastomosis. And for anastomosis, whether you're going to use the same vessel or some other vessel, that is an intraoperative decision and is surgeon dependent. And once you've established, you check the bleed again. And if it is convincing, you come out. Thrombolysis, it is dependent on many intraoperative factors. Generally, we don't give heparin, but if the quality of the artery is very poor, we heparinize. And in salvage cases, as in when the flap goes for re-exploration related to microvascular complication, that time, yes, we heparinize here. Timing is also important. If it is less than 5 hours and you've taken for re-exploration, the chances of survival of the flap are more. And if more than that, then it is questionable. So you should always have a backup plan. Your plan B should be your plan A. Failed attempt at reconstruction may leave the patient in a more disadvantageous position with a worse deformity and suffering. And the limiting factor in these kind of scenarios is a vessel depleted neck, because vessels are limited in that particular area. And also one flap, if you've decided to discard, then you have to start looking for another donor sites. You have to anticipate whether you will be needing a vein graft or not. And you always have to keep in mind why my initial flap failed. So if, again, you should know why it went for a toss, because again, you should not commit that mistake. Because the healing will get delayed and the clock of radiation also is ticking. So you have to be there with a solid plan B. So plan B for salvaging is cephalic flip in venous congestion. It's fairly decent. I think it never goes wrong. So in head and neck surgeries, what you can do is you can go to the DP groove, find the cephalic vein, and go distally, clip it and bring it up. This is very reliable, works always. Or AV loops are described, the correlates loop. And in arteries, you have multiple options. If you're not able to use any of these, you can always decide going to the opposite side. So decision whether we will go ahead again with a second free flap using another donor site depends on the medical status of the patient, the available local options, and the exposed critical structures. So this is what, like a nutshell, whatever we have spoken about. So take-home message is that microvascular free tissue transfer is a reliable reconstructive technique with low failure rates. It is all about anticipation and keeping a low threshold for re-explorations. And early re-explorations are critical for the salvage. There is a steep learning curve and there is no alternative to adequate training. So, two plastic surgeons, Dr. Fu Chan Wei and J.P. Hong, they have told that, the key to learn from a failure is to understand why it happened, and failure is inevitable, they say. And it is important to educate the patient on the possibility of failure. What happens if there are consecutive failures? They say take a break, talk to your mentors and colleagues, or take a vacation. The last one I'm not going to read because it's injurious to health. But, this article is a must read by Dr. J.P. Hong. Thank you.
Thank you, Dr. Radhika, for educating us about the post-operative complication following microvascular reconstruction. Are there any questions for Dr. Radhika?
What's the best way to avoid kinks?
Just a comment.
Yeah, the best way is that generally what we do is we mark the lie of the pedicle using methylene blue. We keep the flap and we see how the flap is falling, how the pedicle is falling from the undersurface, and we mark it with a blue dye.
Sometimes when you open up during the bleeds, you see quite often that initially it will be okay, but then you end up with kings.
No, like you have to be sure. First of all, during inset only it has to start, and later if you feel that it is not holding up properly, then you can. I prefer using Abgel and all to sit them at one place.
Okay. And lastly, after 5 hours, so you think it's still worth exploring, or is it just useless?
5 hours? No, 5 hours.
After 5 hours of
5 days.
you're saying something.
5 days.
5 days. So if there's a flap.
Okay, that slide, yeah. It is generally said that if there is any arterial problem and if you explore it after 5 hours, sometimes the flap goes into a phenomenon which is called as a no reflow phenomenon. So chances of that, wherein even if you do the microvascular anastomosis, the perforator damage and the entire subdermal plexus ka damage is so much that even if you have established a flow, it will not be getting perfused to the paddle of the spleen. So that is why it is better if you're finding it out earlier, and the moment you see it, you intervene within 5 hours.
If not, then the flap has to be taken off.
Not always. Not always. You have to give it a chance. If it works, it works.
I think you said very nicely with venous congestion. You open in the emergency or in the ICU, because that gives a breather for the flap.
Yeah.
I think it will increase your flap salvage rates. And can you comment about when do you extubate the patient, about when do you do tracheostomy, how does it affect?
Okay, sir, tracheostomy here we are not following the free, just doing free flap is not an indication for a tracheostomy here, and we extubate the other day. Yeah.